Moving right away, and I appreciate being joined by my colleague, Senator Ahlquist. You'll find our vote-only calendar on pages 2 through 14, and many of these issues deal directly with core health care services, which are of great need to California at this time. So without objection from the committee, we will accept the staff recommendations to be found on pages 2 through 14. The discussion items begin with the Department of Health Care Services. Mr. Douglas, welcome back.
Thank you. Good morning. Toby Douglas, Department of Health Care Services. Luis Rico, Division Chief of Systems of Care, is going to answer the questions.
Yes. Good morning, Chairman Leno, Senator Ahlquist. Good morning.
Good morning.
As Toby said, my name is Luis Rico. I'm the Chief of the Systems of Care Division, here to respond to and address the questions related to the CCS item. Briefly, the CCS program is a program that's administered in partnership between the state and the local county CCS programs to provide health care services to children with special health care needs who have an eligible CCS medical condition. The program is approximately or over 80 years old. It serves approximately 180,000 children today. A growth of about 10,000 individuals over the last year and a half. One of the hallmarks of this program is the provider standards that have been developed over the decades in collaboration with providers, families, and other stakeholders. And this is a goal and one of the main goals of the program today, which we seek to maintain and advance, again, along with the collaboration of the stakeholders. The department has requested an internal business review process to be conducted by the Department's Audit and Investigations Division. That process will examine the service authorization request process and will include several stages and steps. For example, one of the first stages is to become very familiar with the service authorization request process itself. Will include an examination of the policies and procedures and the other requirements that go along with those, and then compare those with the way that the program is actually functioning in today's environment. The other aspect of this is that the audits and investigations reviewers will actually do reviews of existing staff to get an understanding of the process as it relates directly by and is being worked directly by individuals who are actually involved in the process. We expect and anticipate that the review will begin in mid to late June of next month. In terms of the question number 2, the proposed trailer bill, budget bill language, while we have no specific recommendations or comments about the language, we conceptually agree with the language and look forward to actually working with the stakeholders to advance and improve the program in all of the areas.
Good. That's encouraging.
As well as reaching out to foundations to begin discussions on trying to get funding.
I know we've been struggling with this for a while, so we're hoping this can be a bit of a tool for you and of assistance.
Yeah, absolutely. We look forward to it.
Great. Well, that's what we want to hear. Thank you very much. Do we have any public comment on this? Please step forward.
Good morning. Thank you. I'm Erin Givens with the Children's Specialty Care Coalition. We represent the physicians based at the pediatric tertiary centers that treat the children in the CCS program. And we are also participating in the 1115 stakeholder process, which is looking at CCS pilots and are actively working to try to see those implemented. And as the analysis correctly points out, while those pilots are underway, we do need a strong and vital CCS program operating in the state so that most of the kids will still be in the base program and need to be able to get services. We appreciate all of the time and effort of committee staff who's been working on this issue, and we support the proposed language. There's one other issue I wanted to point out that the department may consider as they're looking at their internal audit, and that is the paneling of physicians and that process. That process currently takes about 9 months. We have a shortage, as the analysis also points out. We do have a shortage of pediatric subspecialists in the state. Currently, about almost a quarter of the total positions that we have in the state are in recruitment right now. There's a national shortage, and California has a particularly acute problem. So if we can try to get physicians in the program in a more timely manner, that would be great, and we'd be happy to work with the department on strategies to do that.
We'll need you.
Thank you.
Thank you, Ms. Givens. Any other public comment?
Good morning, Chair and members. I'm Sharita Lane with the California Children's Hospital Association, and we appreciate the committee's leadership and the department's work relative to this important program. We also are supportive of the recommendations. We're very concerned about the delay in authorizations. We have one children's hospital which has over $11 million that they can't bill because they're waiting for authorization. So obviously this is a critical problem. As Ms. Givens mentioned, we also are supportive of an improved paneling process. Hospitals have physicians that are waiting to be paneled in the CCS program, and therefore they cannot bill the program. And so this would help, I think, alleviate some of the other problems. And then finally, back to the authorization issue on when children are discharged from the hospital, there's delays often in getting authorizations for home services and home equipment. And so we would like to see that expedited, and do appreciate the work that's being done by everyone on the program. Thank you.
Thank you, Ms. Lang. Any questions from the committee? If not, the motion is going to be to adopt the placeholder trailer bill language on page 17 and the budget bill language on page 18, and without objection, that language will be adopted. Moving on to Medi-Cal managed care rates.
Question, Mr. Chair.
Yes,
On
Senator.
the last item, what's envisioned are financial participation from foundations, and the trailer bill language speaks to that. What if there are no willing participants?
Well, I would place a bet that there will be, but we will let Mr. Douglas comment to that.
Sure.
Or Mr. Rico.
We have initiated some discussions with the foundations who have shown interest. They've been very supportive of our process on our 1115 waiver to look long-term at our CCS program and redesigning it, but acknowledge that's going to take several years. So they are interested in also assessing the current structure of CCS and ways that we can continue to create more efficiencies in the process to make sure that we're getting the best outcome for the children. So we think we're going to get there with the foundations. If not, our interpretation of the language is that we wouldn't be compelled without the language, but we are, as Mr. Rico said, we're working internally. We think it is something that we have to, we are meeting too often with stakeholders with the current problems, and I'm sure you all are getting contacts from within your districts, and we are trying to figure out ways to improve the process, so we want to do it and think it's a great idea.
So with or without the foundation financial participation, the need to be assessing as is envisioned would proceed?
Would proceed, yes.
On an internal basis?
Yeah.
Okay. Thank you, Mr. Chairman.
You bet. Thank you. Thank you, Mr. Douglas. So then moving on to Medi-Cal managed care rates. Thank you, Mr. Rico.
First, I'm going to give a quick overview of our rate-setting process as requested. Back in 2007, we had a study by Mercer Consulting looking at our rate methodology. And before 2007, we had developed our rates based on data from 5 of our plans, our county organized health system plans, and taken that data and used it to extrapolate across all our counties and set up plan-specific rates based on this one set of data. We realized that this was not, while the rates were actuarially sound, we needed to move to a rate methodology that relied on plan-specific data, and that was one of the big recommendations that Mercer had. I'll talk about some of the others. So what we do now in the rate methodology is use each plan-specific encounter and claims data We then review that's the most recent, complete 12 months of data. We will have our actuaries as well as our consulting actuaries review it for completeness, review it to make sure that there are no outliers in terms of the costs. We then will meet with the plans to discuss the data that they have included, make sure that it's accurate and complete. We break it apart into different categories for adults with disabilities, with our families, pregnancy. We do trend studies to make sure that we do the accurate trend, taking their data that's about a year and a half old and then trending it forward. And we then create plan-specific rates. And that's what we were doing for the first couple of years, which is plan-specific risk-based rates. One of the other recommendations in the Mercer consulting report was to, as well as part of the statute, said for plan or county-specific rates. And both Mercer said look at counties as well as look at risk adjustment. And the value of looking at risk as well as a county-based rate is to take into account across a geographic area what is going on with the cost of services as well as the risk of the population. Because the goal of a payment methodology is to, as most accurately as possible, make the payment associated with the risk as well as the cost of doing business. So we began embarking last year on moving to a risk-based, county-based methodology where we used a tool called Medicaid RX, which takes prescription drug information from the plans. This is complete data because prescription data is compiled through the pharmacy to back to the plan, so there's complete information on prescription drugs. It's been validated, this Medicaid RX is validated by actuaries nationally as one of the best approaches to identify risk. And use that to determine the risk of the population in each plan and compare that to the other plan in the county. So there are two plans to compare the risk of the populations in those two plans. And then what we do is we take the average rate of the county, taking the two plans' rates and averaging them based on weighting it based on the population and taking into account the risk, and that readjusts the rate. Now, you could do this by taking 100% of the rate and risk adjusting it. What we determined was the best approach is to gradually implement county-based risk-adjusted rates, knowing that one goal is to align the payment to the risk as appropriate as possible of the population. But also, we don't want to do this overnight. We have to know that plans have to transition both in terms of their contracting processes and the way they pay rates, so that we didn't want to go from 100% overnight. And the other issue is
20% then an arbitrary number?
20% is a starting point that reflects the commitment to moving in this direction, but also acknowledges that we can't do this overnight and that there are other factors that we need to take into account. By doing 20%, that means that 80% is still related to the costs specifically to the plan, and would take into account factors such as reliance on the safety net system if they were in fact paying more. That gets to the big question. Our plans have been very supportive of the new methodology. I'd say that's universal. Where there is concern has come up about the issue of county-based risk-adjusted rates. And concern has been raised that this risk adjustment does not take into account support of the safety net system and is going to disadvantage those plans that have targeted more resources to the safety net. We have received information from the local initiatives that looks at how much their investment in the safety net system. We are trying to validate that information. We've asked for follow-up data from the local initiatives because the data isn't reflecting what we actually found. We did an analysis of 4 counties and determined that when we looked at the public hospitals, the per diem payments to public hospitals across the commercial and local initiative, the per diem payment rate was very similar. The utilization rate of public hospitals was very similar. Now, of course, in magnitude, the local initiative, since it has a lot more members, had a lot more days in the public hospitals, but as a proportionality of their overall utilization, it was very similar.
And you said this was in just 4 counties?
We did 4 counties. We did L.A., we did Alameda, Santa Clara, and San Francisco. FQH, Federally Qualified Health Centers, there are rules that require plans to pay all providers, physicians at federally qualified health centers the same rate. So they can't target additional payments to the federally qualified health centers. We as a department are also required to then what's called wrap around the payment that the health plan makes to make the federally qualified health center complete in its payment. It's receiving what's called a cost-based, a prospective payment rate. It has to receive that payment, and the department will make sure that it receives it, not the plan. So again, it's hard to know that the federally qualified health center is actually that there would be a difference for the local initiatives. Now, some local initiatives we will acknowledge do what's called pay-for-performance payments that are end-of-the-year payments that would be on top of their physician-based rates that they'd be paying equally. That is possible that they are putting more payments into the federally qualified health centers. We don't have the data, actually, the way our data at this point we don't have to be able to figure that out, so that would be a further analysis. The bottom line is we fundamentally believe that the safety net and preserving and improving is a central role of our department. It's a central role of what we're trying to do on the 1115 waiver. It's a central role of us getting to, as a state, to 2014 and being able to make sure that we have the capacity to ensure that we have sufficient providers within our system. And we believe that the way we do our certain performance measures within our default enrollment, we have measures that reward safety net participation. We have contractual requirements. And then, as I said, we have a risk-based adjusted rate that is at 20%. There are considerations of continuing to move it forward, but we are nowhere near at this point moving to 100%. And to the extent we aren't at 100%, any percentage component of the rate that's set aside for health plan specific rates is then taking into account the actual use and cost of that plan and their targeting of the safety net system. We're very concerned about the trailer bill language because what it does is it will mean that we cannot increase beyond 20% on a risk-adjusted rate. And in fact, what it does is actually reduce our ability to do risk adjustment because it pulls out of our methodology all expenditures related to public hospitals and federally qualified health centers from the calculation, and then makes a calculation based on the residual, which means that it would be less than 20% risk-adjusted rates. We think that it's important that we continue these discussions. The focus on the safety net is important, and we're happy to sit down with our local initiative partners, our commercial plan partners, to continue the discussion how we better add this component of safety net use into the equation, but it needs to be done in a way that does not undermine our focus on county-based risk-adjusted rates. Thank you.
All right. Thank you for your comments on that.
Okay.
Our notes show that under the 20% risk adjustment factor that the local initiatives would be reduced by about $7.2 million in capitation payments.
And that is correct. The way again, we look, there are certain counties where you have differences in the rates of, some cases per member per month of $110 to $150 per member per month. Serving same populations, we take into account the risk of the population, and again, very similar. So then what explains that difference? And part of a county-based risk-adjusted rate is to say, well, the cost of doing business shouldn't be that different, so we're going to do a weighted average of the cost of doing business across that county, and then taking into account the risk. But we have only done that on 20% of the rate. If we don't start taking into account these factors of risk, the cost of doing business in a county, then we're not able, as a department, to determine what are the true reasons and what are the justifications for having differences in rates in the same county. And there are other factors, like the use of the safety net, and we're willing to discuss that. But risk, the county cost of business, you also hear about very big concerns about looking at efficiencies, such as unintended use of the emergency room or inpatient use, overpricing of prescription drugs. There are lots of different measures that over time we need to continue to do to refine our methodology. It is a methodology that we feel has advanced the department considerably in its use of paying plans appropriately, but still needs work.
Thank you, Mr. Douglas. Before we get to public comment, does the LAO have a thought on this?
Thank you, Mr. Chair. Meredith Worden with the Legislative Analyst's Office. At a prior hearing, you requested that we review this new methodology, and I'll note we are still in the final stages of our review, and we'll be able to provide you with something prior to the May revision committee hearings. We'd also note that we've identified some transparency issues with this new methodology in that it wasn't identified in formal documents that are submitted to the legislature and available publicly, such as the Medi-Cal local assistance budget request. There are assumptions in that document that outline various changes in policy, and this is one place that it could have been and it was not. So we'd just like you to note that.
So we should have your assessment, in about a week or so?
At least, yes.
Within the week. All right. Thank you.
And I do want to say that's a fair point. We need to be more transparent on this, and we're working on the revised process, whether in the estimate or separate, to make sure that our colleagues, whether in the legislature or the Legislative Analyst's Office, have more information on this.
Thank you. Public comment.
Mr. Chair, members, Jim Gross on behalf of the Local Health Plans of California, which cover 9 counties, including 3 counties represented by the members of this committee. Very briefly, I just want to say that this conversation with the department and the agency started about 9 months ago when the local health plans went to them and explained our concern about not only the countywide averaging and its impact, but the failure to have any elements that would take into account the support of the safety net. And that conversation continued, but we got to a point where we believed it was appropriate for us to propose a mechanism for dealing with that issue, and that is what you have before you. I have with me Brad Gilbert, Dr. Brad Gilbert from the Inland Empire Health Plan, who can go over some of the more salient points on this issue.
Thank you, Mr. Gross. Dr. Gilbert.
Thank you. IEHP is the local initiative for Riverside and San Bernardino counties. We serve over 375,000 Medi-Cal members, 450,000 members total. And I think what's important is to remember the history of how Medi-Cal managed care started. I was there at the time. I was employee number 10 of IEHP, so I've been there from the very beginning. And the local initiatives were specifically created to really take care of the safety net and traditional Medi-Cal providers. We are creatures of the counties. The counties create the local initiatives, they approve them, and in fact, all of us have county supervisors on our board. So, for example, 4 of my 7 board members are county board members from the 2 counties. And so our charter was clear. It was to protect, enhance their capabilities, and provide resources to the traditional and safety net providers. And those are really focused on public hospitals because of the vast majority of Medi-Cal care was provided there back in the day. And 2, that federally qualified health centers and traditional primary care physicians. So that really was our charter. And there were historical rate differences that were created to acknowledge that fact, that that really was the point of the local initiatives in the process. The key providers that we interact with a wide range of providers, but our public hospitals, the federally qualified health centers are key. We do additional payments. We do pay for performance. We do payments beyond just the traditional, do something and get paid for it. For example, we just started a diabetes clinic with Riverside County Regional Medical Center, which is the public hospital in Riverside. So that's a special project focused on making sure that particular key part of the network, can provide the care that it needs to do. We do not object to risk adjustment. That is absolutely a critical part of determining how people should be paid. The federal government has done it with Medicare for years. Great job. The state is embarking on that process. Our problem is the countywide average, because it literally takes that historical rate difference, which, by the way, has been validated by Mercer when they do their plan-specific rates. So they validate those rates when they do the plan-specific rates. It then just mushes those rates to a county average. It then applies risk adjustment on top of that mushed average. So that automatically results in a transfer from the plan that had that higher rate that is validated by Mercer essentially to the other plan. Just a comment, IEHP actually does better under the countywide average in the risk adjustment because we happen to be paid less than the other plan that's in our area. But we still support the idea that one of the reasons of being of the local initiative is that connection to the safety net. And so having a safety net adjustment that takes into account the differences in payments. For example, straight from the rate development worksheets is the difference in FQHC payments. So that is the department's own data that shows that we provide significantly greater services on a per member per month basis. County hospital, a little more complicated. Most of that is self-reported data from the county hospitals, and we're working with the department to try and get that data to be better able to be quantified. So be clear, we support risk adjustment. We have difficulty with the countywide average, and we believe this safety net adjustment takes into account that history and part of the differences between the health plans.
The historical perspective is appreciated and valued. Thank you, Dr. Gilbert.
Yes, Mr. Chairman and members, Terry Thomas on behalf of the California Association of Public Hospitals and Health Systems, and I think, as you know, we are the key component of the healthcare safety net in the counties. I think Mr. Gilbert did an excellent job of going back historically about the development of the local initiatives and the important role that they play. And I also appreciate the comments from Mr. Douglas about the recognition on the part of the department about the need to ensure that the safety net not only survives but flourishes and improves as we move toward 2014 and implementation of healthcare reform. We support the recommendation in the analysis made by the consultant. We think it takes into account the need to carefully examine this issue before we move forward too quickly. I think that it's just really obvious that when you do something like this, that there are going to be winners and losers. And I think we all recognize that when you adjust some people down and some people up. And for the public hospitals, the key is to ensure that that adjustment, if it's on a downward slide, doesn't go to the point where the safety net can't embark on the important kinds of programs that Mr. Gilbert described, as well as to make those system improvements so that they are there to care for people in 2014 when healthcare reform is fully implemented. Thank you.
Thank you, Ms. Thomas.
Good morning, Chair and members. Allison Ramey on behalf of the California Primary Care Association, representing over 800 community clinics and health centers. We, too, support the trailer bill language that's in front of you and acknowledge and appreciate the relationship that our clinics have had and continue to have with the local health plans. We recognize them as an important partner in our ability to deliver the services that we do and, again, support what's in front of you. Thank you.
Thank you, Ms. Ramey.
Mr. Chair and members, Sharita Lane with the California Children's Hospital Association, and we very much appreciate the efforts and the discussion around supporting the safety net, but there is a component that was not discussed today, and that is the private hospitals that comprise the healthcare safety net in California, including the children's hospitals. Children's hospitals have in aggregate over 50% Medi-Cal, and some hospitals have upwards of 70%. So just a comment for your further consideration. Thank you.
Well taken. Thank you, Ms. Lane.
Mr. Chairman and members, Dan Chick with HealthNet. HealthNet is the commercial provider in a two-plan county in Los Angeles as well as in Kern County. As you can imagine, we have a different perspective on the proposed language. We would suggest that the language be held in abeyance and possibly until the LAO can give us their report. But we'd like to today put a little perspective on why we think county-specific risk-adjusted rates are important for us. In the past, when there was a rate differential and we would go to the department and say, well, why are we less or why are they more in a particular county as far as our rates are concerned, and we were often told, well, we think your population may be sicker or healthier. And so the move towards having a risk-adjusted factor in there is an ability whereby we can have empirical data to say, in fact, and mind you, we're okay up or down how this would turn out. If, in fact, our population was healthier, then our rate should reflect that. So we ardently support the move towards risk-adjusted rates. We think capping it and not allowing it to move beyond 20% is not in the best interest of the whole system. And to elaborate a little further upon that and to talk a little bit about the language, mind you, we just received it last night, so we haven't had time to model it and see how it would work out for us, but we do have concerns with the language. I brought with me today Dave Meadows. He's our Vice President of State Health Programs, to give some perspective on it as well.
Thank you, sir.
Thank you. Again, Dave Meadows, Vice President of State Health Programs for Health Net of California. First of all, I know that there was a 7.2 million was mentioned a little bit earlier, and I think I'd just like to point out that I think that 7.2 probably is a little bit misleading in that that appears to be the differential from the plan-specific rate to the county-wide rate pre-risk adjustment. So it ignores the risk adjustment component of it. And if you have county rates, you have to have the risk adjustment and the county rates. They go together. They're a package. You have to consider them together, not individual components of that. So if you factor in the risk adjustment to that, that mitigates a large part of that 7.2 million. I think it probably cuts it down maybe even as much as half. We think, though, the risk adjustment concept, the whole concept there is you're paid more for your sicker members that use more services. They cost more, so naturally you should be paid more. So risk adjustment, we think, is a good thing. It's not based on whether or not you're a commercial plan or you're a local initiative. It's just based on whether or not you have the sicker population. I think there's been an assumption now for a long time that the LIs have been paid more because they have the higher risk. Well, true risk adjustment will now give us an opportunity to quantify and actually substantiate the assertion that's always been made in the past. And if it is true that the risk is higher, then risk adjusters should pan out and indicate that. So again, the differential, I think the numbers, some of the numbers you've been shown do not include the risk adjustment component of those numbers, and it would mitigate it again quite a bit. I think that the assertion that the risk adjusters don't recognize the safety net risk, well, if your safety net providers have sicker patients that cost more, yes, risk adjustment would recognize that, would incorporate that, would include that in this part of the rate. And I think there's been an assumption that the commercial plans, they don't use the safety net providers. Well, commercials do use safety net providers. We have to. They are an absolute, critical, essential part of our network. We can't function without those safety net providers. We need the providers to provide the services to the population that we serve, and that is largely those safety net providers. So yes, we use them also. In fact, many of the commercial plans, I think, have a higher use of the safety net providers in many of the counties than the local initiative. We operate in Los Angeles County, for example. In Los Angeles County, 70% of our admissions are to DSH hospitals. Only 65% of LA Care's admissions are to DSH hospitals. Another county we're in is Kern. In Kern, 70% of our admissions are to DSH hospitals, and only 56% of the local initiative days are to DSH hospitals. So we actually have a higher percentage of admissions to DSH hospitals than the local initiative. We are doing lots and lots to support the safety net. I think that also that proposed formula, I don't think really recognizes the full network of safety net providers. For example, it doesn't seem to include the DSH hospitals. It just includes certain designated hospitals. And I think that there are a lot more providers that are essential to the safety net, and they should be considered part of the safety net. It also doesn't recognize a lot of the other essential providers that don't meet the technical definition of a safety net provider. In LA, for example, there are numerous medical groups there that are predominantly Medi-Cal providers. That is their core business. That is their primary business. That's what they do day in and day out, is treat the Medi-Cal population. And they're absolutely essential to the provision of the services to the Medi-Cal population, and they have to be supported also. And we do a lot to support them. And you cannot have an adequate network without them. So I think it's also there's no indication that the safety net really costs more. I think Toby mentioned this. It doesn't really. There's no evidence that the safety net providers actually are more costly than the other providers that would be in your network.
Sir, if you could conclude, please.
Okay, I will. In the formula, I think that by the way that it goes through and it factors out the safety net, I think it actually does impair the integrity of the calculation, impairs the integrity of the risk adjustment determination. It seems to be done somewhat after potentially the determination of actuarial soundness. So I think it also really puts into question the whole actuarial soundness determination.
Thank you. Thank you very much. Any questions from the committee?
Mr. Chairman?
Yes.
More Maureen O'Haron from Molina. Could
How
I
did I
also
miss you?
comment? Yeah, I sat around with
Please.
my friends here.
Go right ahead.
Thank you, Mr. Chairman. Maureen O'Haron, representing Molina Healthcare of California. I think we share a number of the concerns expressed by HealthNet that this is moving a little too fast. We just got the language yesterday. We support the department's move, down this path of the Mercer methodology, where we're suddenly going to look at what it really costs to provide health care and not just build in a rate and do a budget adjustment. We do have a lot of concerns about a lack of transparency. I think the department has tried to be more transparent in the past couple years, but Molina is struggling, for example, with the San Diego rate negotiation. And yes, that's GMC. It's a little bit different process, but we still have significant concerns that there's too much in this black box. And this whole discussion sort of throws open that problem. We think that the plan should have more time to review changes like these countywide averaging and risk adjustment. The department is currently talking about an efficiency adjustment. And we are all very concerned about that. It's moving way too fast. And from our perspective, we're already getting paid way below what it costs to truly provide health care. Everyone in the Medi-Cal program is, and everybody knows it. To impose yet another, an efficiency adjuster, when we are dancing as fast as we can to make sure we keep people out of the ER, that we get them their care, we just can't. It would be a net loss too, across the board, and so that's a significant concern. We definitely need more time on this language. We would really ask that you not even adopt it as a placeholder. There's significant concerns. I think it's Dave Meadows pointed out. The definition of safety net provider selects only 2 different types of safety net provider, leaves out non-FQHC community clinics, leaves out Indian healthcare clinics, leaves out non-designated public hospitals, and we have questions why. And the big question is, why should these safety net provider payments be protected from countywide averaging and risk adjustment? We still haven't gotten our heads around that. Historically, as Dr. Gilbert pointed out, the local initiatives have been paid more than we were as commercial plans because they were mandated to use the safety net. That doesn't mean that they used it any more than we did. And in fact, Molina, like HealthNet, uses the safety net more in, I think it's San Bernardino County, both on the hospital and primary care side. And we also beat our friends IEHP on the hospital side in the other county. In San Diego County, we use 95% of the safety net providers, the designated safety net providers. And we appreciate that this language is not tilted, expressly towards the local health plans. But, the question comes back. If both types of plans in these counties are using the safety net to pretty much the same degree, as Toby Douglas said, then why are the costs different? The costs are different because historically they've been paid more. And you spend what you get. And so they've been able to pay their providers more all these years. And so their cost data is going to reflect that. We're always going to be struggling and behind and unable to pay our providers adequately if we don't have some sort of averaging where we're brought up to some par here. And so really, this needs a lot more time and thought, and we really would ask that you put this over, let us all meet and discuss it.
Thank you, Ms. O'Hara. Mr. Douglas, you have any further comments? I think Mr. Gross does.
Yes, if I could, Mr. Chair. We appreciate the comments from HealthNet and Molina because we think they acknowledge the fact that the current methodology does not take into account the safety net. What they're arguing is that there may be more factors to be considered, and they want to look at that. But it doesn't seem to me that anybody here today said that the methodology the department has embarked upon with 20% and would go to 100% takes into account the safety net at all. Mr. Douglas may want to correct me, but I don't think that's the case. So I think overall the case has been made. The safety net has to be considered. Thank you.
Very good. We're going to leave it at that. We've had a full discussion. If you want to make a final comment on this, otherwise, Senator Ashburn.
Yeah, Mr. Chairman, is it anticipated that there will be any budget savings as a result of the adoption of this proposed language that no one's had a chance really to fully evaluate?
Well, let me try to answer it this way. Part of risk adjustment, county-based risk-adjusted rates, one of the other components, what it does is by creating a comparison across the county, it does give plans the incentive to make sure, one, it gives the incentive that if they're going to be rewarded if they are seeing a riskier population, that they don't have to worry and try to cost shift away the riskiest population. And two, if their costs are unusually high, it gives them incentives to be better, to make sure that they're spending the funding as efficiently and effectively as possible, so getting the best value out of the system.
But we've already acknowledged that, at least in the 2 counties, the bias has been, up to this point, with the not with the private plan. And the bottom line here is, we've got a budget problem. Surprise. Is there savings anticipated in anything that is before us in this trailer bill language?
I don't believe there's.
Then why are we doing it?
Well, I think
why adopt this language? What are you going to achieve in terms of budget impact? Why not take the time so that LAO can evaluate as they're evaluating, and that we can have this discussion on outside of the context of the urgency of dealing with this severe budget problem?
Let me clarify. Mr. Douglas is not advocating on behalf of the language, but I'm going to let Mr. Gross.
No, I'm looking at him, but I
don't think it's a rhetorical question.
No, I'm asking,
right. So,
I'm asking
Mr.
the chair. I'm asking the majority.
Through the chair, Mr. Ashburn. The current methodology the department is using also does not save money. What this is moving money around.
Yeah, between these 2 competitors.
Right.
But this is not the forum to do that.
Well, you're on the committee. I have to say I respectfully disagree with you on that. The point is that this methodology affects how Medi-Cal dollars are spent. And our point is you need to have the right factors. And the current methodology does not have the right factors. And so we didn't propose legislation. What we proposed is that the Budget Committee understand what the impact of this was, so that, in fact, it could address...
But was that not the purpose of the Mercer study?
No, the purpose of the Mercer study was not to come up with countywide averaging. And now we have this injected into the process.
To come up with criteria.
I need to disagree. The Mercer methodology specifically calls out risk adjustment and looking at county. The only way to do risk adjustment, and you can't do risk adjustment without trying to what's called normalizing the population, either across a geographic area. It could be multiple counties.
Mr.
So you have to do that.
One second. We're going to let Mr. Gross finish his sentence. We're going to let Mr.
Sure.
We're going to let Mr. Douglas finish his sentence. Okay. You will then get to make your comment. Mr. Gross, you've been very helpful. And then we're going to move this issue forward and get on to our next item. So if you'd like to finish, and then Senator Ashburn wants to make another statement.
Sure. Thank you. So back to Mr. Gross's point about that it doesn't save money. This gets to over our budget year, no. But we do believe over time you're changing the trends by trying to create the right incentives, both in terms of better care, by incenting serving a more costly population, as well as better use of the dollars spent. That should change trends over time. There is cost efficiency in the methodology, and that's what we're trying to drive to.
Very good. Senator Ashburn, if you'd like to make a comment.
And I heartily endorse that approach. Regrettably, the trailer bill language moves in the opposite direction. We have competitors here, and often is the case, competitors are looking for best advantage and greatest reimbursement. This is not the place to do it unless you come before us, someone comes before us and says, do this, and we save money in this year's budget. Okay. That's not the case.
Thank you. So just to put a final word on this, the reason this is the proper forum for this conversation and debate is because the department has come forward with this 20% plan, which we never asked for. And so we're discussing that now. We've asked the LAO to give us their wisdom. They'll have that to us probably within the week. At this time, I'm making the motion that we adopt this trailer bill language as placeholder, so we can continue this conversation through the budget process. And I think we might want to call the roll on that. Call the roll, please.
Senator Ashburn?
No.
Senator Leno?
Aye.
Senator Alquist?
Aye.
So that will be the action.
I was going to win that.
Thank you, Senator Ashburn. Thank you all for your participation in the conversation. Mr. Douglas, we'll move on to physician-administered drug reimbursement rates.
Right. Pilar Williams, our Division Chief of Pharmacy, is going to present.
Thank you.
Rushing up to the...
I'm very sorry.
Welcome.
Good morning. I'm Pilar Williams, Chief of the Medical Benefits, Pharmacy Benefits Division. The committee had asked that DHCS explains the trailer bill that is being proposed and also the proposal for additional staff. As you may know, the Department of Healthcare Services currently reimburses physicians as what's called average wholesale price minus 5%. The pharmacies, on the other hand, are reimbursed at what is again known as AWP minus 17%. So what the department is proposing through trailer bill is to change the reimbursement for physician-administered drugs. These are drugs that are given by physicians at the physician's office to either match the pharmacy rate or establish it at the Medicare rate, which is currently at what's known as average sales price plus 6%. One of the reasons why the department is proposing to do so is because of the fact that average wholesale price will no longer be published as of September of 2011, and I will get to that point in a second. So the position that is being requested would be to do several things. We are also requesting funding to do a study to ensure that the rates that are set are consistent with federal requirements. So there's several things that the position will do. Obviously assist the vendor with all of the things that need to be done to get the rate setting done, and also the rate study done, and also to do the rate setting, because what happens is the codes that are used for physician drugs are very different from pharmacy. So in order to find the one-to-one match, there's a lot of work that needs to be done. Now, new rates come into play all the time when new drugs come into the market. So this is something would be ongoing work. We have in the budget, I believe it's $30 million currently on an annualized basis in savings as a result of this proposal. So that's what the position would help do.
I think we have that pegged at about 26.3.
It's due to the lag factor that we use to do the rates, to do the savings.
Right.
On the second question related to what will happen with AWP when AWP goes away, in the interest of the committee, back in 2009, in March of 2009, a settlement was reached between First Data Bank and a series of labor and entities. As part of the settlement, First Data Bank agreed to reduce their AWPs by 5 percentage points, which happened in September 2009. And in addition to that, and sort of independent of the settlement, First Data Bank also agreed to stop the publishing of AWP 2 years after that September 2009. I understand the agenda says October, and it's because it's at the end of September, so September 26th, so it sort of gets into the October date. So the department will work with the stakeholders and other entities on a new benchmark that will take the place of AWP.
Thank you for taking a very complex subject and making it understandable. Do we have any public comment on this? And LAO, do you have any thoughts?
Thank you, Mr. Chair. We have no issues with this proposal.
All right. Any comment from the committee? The motion then is to adopt the proposal, and this includes the placeholder trailer bill language, and also to approve the request for the pharmacy consultant to position.
Thank you very much.
Without objection. Thank you. And now, at the request of Senator Ashburn, we're going to have a discussion of the Bureau of State Audit's report.
Hello, Mr. Chair and committee members. My name is Renee Malo, and I'm with the Department of Healthcare Services with Medi-Cal Eligibility Division. And I'm here to provide a brief summary of the key actions that the department has taken to respond to the audit. We did conduct a more detailed analysis of the case error findings of the counties that were in excess of 10%. This helped to isolate the findings that were within the control of the counties. Such findings included appropriate determinations of eligibility, looking at determinations for individuals for full scope and limited scope services, looking at share of cost determinations, and then looking at the counties conducting mid-year status report evaluations and annual redetermination reviews within required timeframes by the state. Our findings demonstrated that most of the individuals were eligible for services, but that case documentation didn't always adhere to the policies and procedures, resulting in the error findings. Department staff have met with the specific counties with case error findings that were in excess of the 10%, which include Fresno, Sacramento, San Joaquin, Santa Cruz, Merced, Monterey, Madera, Stanislaus. And we also performed some focus reviews with Fresno, Madera, Sacramento, and San Joaquin counties. The meetings with these counties included detailed discussions with the counties regarding the error findings, and also discussed mitigation steps that the counties would take in terms of correcting the identified errors. There were written letters that were sent to the counties documenting what these efforts were. We've also performed an overall review to the extent to which the counties had corrected the errors, and in over 95% the counties did demonstrate correction. Common reasons for the error findings included issues with the counties having adequate staff resources, increased caseloads that they had to deal with, furloughs, and problems with system automation, and then prioritizing applications versus looking at annual redeterminations. County mitigation steps have included working towards improving their automated systems, hiring staff on a temporary basis to the extent that they're able to do so, doing additional staff training, and in some cases, some of the counties have worked towards increased automation or increased efficiency, such as establishing call centers. Our MEQC efforts that we conduct for the counties in terms of looking at eligibility determinations are really designed around ensuring program integrity, and we conduct these reviews with the counties on a semi-annual basis and look at prior trend reviews with the counties to then help determine the additional focus reviews that we need to conduct. And our goal is to work with the counties on an ongoing basis to help reduce these errors. And I'm happy to take any questions at this time.
Senator Ashburn, you want to take the lead on this? This was at your request that we have this discussion.
Right, and I appreciate that, Mr. Chairman, because the principle behind all of this is that if the people of California are going to offer services, that the people who enroll in these benefits are actually eligible for them, and that those who administer them at the delivery level within the counties, that there be an accountability for the delivery of these services, and that accuracy be of the utmost importance. So I appreciate the review and the report back to the committee on this. I am concerned, however, that again, given the severe budget constraints facing this, that the response, the role of the state in overseeing and monitoring the performance at the which is delivered at the county level is in the form, as I understand it, of action letters, notice of error and a desire that things be changed. I mean, doesn't this require a more serious response for recovery, for example, of funds paid out that are to persons who are ineligible?
Well, we, besides the action letter, we're out there meeting with the county representatives, going through the cases and working on a corrective action plan together. So it's beyond just the letter; it's also a continual quality improvement effort. Because just as you stated, it's our belief that any dollar that's going out for someone who is ineligible is a dollar too much. We need to make sure that we're meeting 100% targets. Now, in terms of the idea of penalties, The statute a couple of years ago did have penalties, but because of actions taken to reduce county administration, it was also we took out the administration, and the legislature took action to take out the any penalty on the counties. So at this point, given the resources that are going to the counties, we're looking at other ways, which is through our efforts to get out to the counties, continue to provide oversight, continue to work on best practices, and try to keep the error rate as low as possible with the goal of getting it to zero.
Thank you.
Very good. And we have a note here that to reinstate the fiscal sanctions, that we'd have to discontinue the geographic sampling plan, and that's not something you advise.
That's it. The federal what would happen then is both. We would be putting ourselves as a state at risk at federal sanctions, as well as then there'd be potential we could go after counties, but it puts us in a fiscally vulnerable situation too. Plus would require extensive additional resources to do not just 25, but all 58 counties. And they, as the write-up explains, the 25 counties is where about 95% of the population is. So it wouldn't be cost effective, but we do need to drive the rate to zero.
That's always the goal. Thank you. I think we have some public comment on this.
Of lecturing at the lectern. Thank you, Mr. Chair and Senator Ashburn, Kathy Senderling.
We don't mind when you lecture.
With the County Welfare Directors Association. That comes post May revise. Wag the finger.
I'd rather receive one from you than Frank Mecca any day.
Thank you, Senator. Duly noted. I appreciate the opportunity to comment and really echo the comments of both Ms. Mallow and Mr. Douglas on this. The counties take performance extremely seriously, and the MEQC audits, which are a separate performance structure from the performance standards that were enacted in 2003, are taken very seriously by the counties, even though there's not a penalty involved. I've had instances where counties will call me after extensive discussion about an error, one error, even though there's no penalty involved, even though they can sort of take the error, say that they'll correct it, work with the state, and there's not a penalty involved. They don't want that error on their record. They don't want that letter to go to their boss. And so we've gotten involved in some occasions, for example, with the citizenship requirements that were put into place a few years ago, where at the CWDA office we helped to work with the quality control folks to develop the cookbook that they use when they go out to review our staff, because the staff took it very seriously. It wasn't just about developing the upfront and sort of front-end instructions and making sure that we knew what we were supposed to do. It was also understanding how we would be reviewed to that and making sure that the counties understood what the rules were going to be and how our cases were going to be reviewed. So again, even though there's no outright penalty, and we agree that any opportunity to penalize doesn't make sense when we're being underfunded as we are. The counties have been cut by about $275 million, and that's just over the last 2 years. So in 08-09 and the current year. Certainly we're not sure yet what the May revise holds, but already there's been another proposed cut of around $44 million in the coming fiscal year. We're seeing increased applications because of the recession, and also county eligibility workers tell me that people are staying on the program longer. Those pieces of paper that we chase people for, the mid-year status report, the annual redetermination, more folks are making sure to get those in on time because they do not want to lose coverage in an economy like this. And I'm also told that there's a lot more parents who started out just with the children on Medi-Cal. The parents are also now asking to be added on because they've lost their job, their hours have been cut, or their employer has cut back or eliminated health insurance. So we're seeing more complex cases because a lot of those folks have retirement accounts, they've got assets, they've got 1 or 2 cars, and making sure that we appropriately account for all those and make sure that we are doing accurate eligibility determinations is extremely important, especially in this budget climate. So I'd be glad to answer any questions, but I did just want to reinforce what the state had said.
Always informative. Thank you. Anyone else? Public comment, please. Take the lectern.
Randy Hicks, California's Disability Rights. I use Medi-Cal. Ms. Sedlak said it right. Counties are in trouble. We got, just in Sacramento County, $181 million in debt. They're going to slice up 20% across the departments. That's what I learned last night at my commission. 20%. Now take 20% of 20% of the staff who's going to have to do A, find new people to get on Medi-Cal, B, do redeterminations. I already got a redetermination letter. It's 5 pages. 5 pages. Only 3 pages apply to me. Can you imagine going through all 5 pages and then say, well, no, he didn't need those 3. We don't know why we sent those 3 out to him. So the counties are in big trouble. I'm on a commission now. I'm not representing the commission, but I'm in the commission now. We're going to lose one of our best staff members because of county cuts. This is just another burden they don't need. So I say we do everything to support the county and support Medi-Cal citizens, because almost every member of our organization is on Medi-Cal or Medicare. So thank you very much.
Thank you, Mr. Hicks. No other questions? Discussion concluded. Thank you.
Thank you.
Thank you. And then our last issue with you today, Mr. Douglas, is Medi-Cal Management Information System.
Good. And Karen Johnson and Donna Martinez are going to present on this item.
Good morning.
Ms. Johnson, welcome.
Good morning, members. The subcommittee agenda asks for us to provide a brief summary of the project and the need for the requested positions. California Medicaid Management Information System is the largest and most complex system, processing system in the nation. Today, it is responsible for processing and adjudicating nearly $19 billion in Medi-Cal claims. It is a 30-year-old legacy system, and it's been modified several times. A recent assessment indicated that the core components are beyond the end of the life and recommended that the effort to replace the system should begin immediately. We are requesting an extension of 11 positions and 24 new positions for a total of 35 positions. All of these positions are limited-term positions, and they are responsible for coordinating and managing the transition from the current contract to a full implementation of the replacement system. This team is necessary to provide the adequate private project management oversight to ensure that this massive undertaking is successfully implemented on time and within budget. With me today is Donna Martinez, who will go over and provide a brief overview of the project schedule in front of you.
Thank you, Ms. Johnson. Ms. Martinez.
Good morning, members. The first document that you should have received is a graphical representation of the new contract.
A colorful graphic representation.
Well, there's a very important distinction between each of the items, so I wanted to make sure and try to avoid those colors that one might have difficulty with.
Thank you.
As you can see, we've actually already started the contract. It became effective May 1st, so our first official date of work began May 3rd, and it begins with the takeover of the existing legacy system. That is actually a 13-month transition, with the first 9 months being spent preparing to actually go into operations. So at the end of 9 months, or February 1st, roughly that date, it'll be the first Monday in February, we anticipate that our new contractor will begin the assumption of operations. As part of that, there are new things in the contract that are required, which is the second item on the list, the legacy expansion items. So those are things that we're looking to do in the contract to assist us in better monitoring and managing the things that go on while we have the legacy piece in and as it moves into the new system. After that, we begin the actual redesign and replacement of the system. It begins with business rules extraction, which is understanding what are the department and the state's business rules associated with Medi-Cal. And all during that time, then we also have the legacy operations continuing. Then we start with a breakdown of the various components for the replacement system. We have chosen a phased-in approach that was done as a direct result of research that the department did with multiple states, and to reduce the risk to the state of California in regards to, as we implement, if we run into problems and issues, we can address them timely, as opposed to what is termed as a big bang implementation. What you will also notice on here is we have a number of items that are we call optional contractual services, or OCSs. One of them deals with our HIE-HIT initiative, and another one that we'll deal with during the replacement system is the provider enrollment system. Some folks may be aware of the fact that there had been a previous procurement where the proposed price for that system was $4 million. Under this contract, it's a little over $1 million. We also have included on here for you to be aware of are the other contracts that we're in the process of acquiring to oversee the actual project itself, the IV&V, the project management that we need, as well as an independent architect to assure that throughout the process we have designed and developed a system that will withstand the changes that California has over a long lifetime. So that basically covers what will happen over the next 69 months plus another 60 months. And so what we've also provided you with, in addition, are some things that we believe are important to note in terms of contract protections, changes that have occurred with the new contract in terms from the contract that we're in today with operations to the contract that we have just entered into. And one of the most significant items is we have created additional precedent to payment types of accountability. We've made it more in-depth than what we have in the past. And that is so that we can hold the contractor accountable if we find that they are not meeting our requirements and incentivize them, if you will, to correct whatever issues occur. Then the second part deals with letters of credit. We have added a significant amount of letters of credit, again, to protect the state, one for the takeover process. I will tell you that we received the first letter of credit, which is for the takeover. It was just under $10 million. That is where the state can actually, if the new contractor is unable to perform, we have the right to pull it, and if needed to go to a sole source extension, we'd have the ability to do that and do another procurement. We also have one, a $10 million one for our operations, and then another one for our replacement system, 10%, which again is to assist the state in the event there is a failure and we need to do something different, take a different direction. And of course, we always do liquidated damage provisions, and as you can see, we have significantly increased our cap associated with liquidated damages. In terms of where we're at today, as far as the contract goes, there's a number of things that the department did prior to contract effective date and once the protest was resolved in working with our new contractor. We began setting up our governance for the project and getting folks ready no matter what occurred during the procurement so that we would be prepared as soon as contract effective date rolled around, we would hit the ground running. One of the many things is figuring out exactly what has to happen and what has to change. We've set up our governance, and we are now in the process of assimilating our new contractor into that governance. We're actually only into the second week of the contract, so we are starting to receive the required deliverables on time, and the state is going through the process of reviewing those things. The new contractor has also done a number of things in order to support our efforts. Prior to contract effective date, they held a number of open houses to inform the existing contractor staff the hiring opportunities that they would have available to them, because we want to make every effort to reach out to experienced staff who know how California processes their claims, and they were very successfully attended. They have also set up a website along with their Medi-Cal business partners. They have a number of subcontractors. It includes a questions and answers section to it, and it provides all of the available jobs that they currently have with a timing as far as when they intend to hire over the next 9 months. So that's where we're at today, and do you have any questions?
Well stated, thank you, and the timeline really does help. And it would appear that much of your timeline almost overlaps with the unveiling of the federal health care reform, so this is just in time. Did you want to make a comment? All right. Elio, I know you had recently opined on this issue. Anything to add at this time?
Not unless you have some specific questions.
Okay. We'll leave it at that.
We're recommending against one of the positions being approved, as noted in the agenda.
And we're fine with that recommendation.
All right, we'll consider that. And public comment on this issue? All right, I think it comes to all of $15,000. We had thoughts that given the 9-to-1 match, that with the 1115 waiver proceeding and also with this project, that it might make sense to hold on to that last position, but without objection, we'll follow the LAO's recommendation, save a few pennies. And without objection? Without objection. That is the order of the committee. So, thank you, Department of Healthcare Services.
Thank you.
Keep up your good work. Mr. Douglas, you've got a good team with you.
Thank you very much.
Thank you, Ms. Martinez.
Thank you.
And Ms. Johnson. So, Department of Public Health.
Mr. Chairman.
Good morning.
Good morning. Brian Liu from the California Department of Public Health Office of AIDS. In regards to this item, existing statute that allows HIV counselors to conduct rapid HIV testing requires these counselors to be trained by the Office of AIDS and funded by the department. Due to the loss of general fund support for HIV counseling and testing in 2009, there are up to 41 local health jurisdictions that can no longer provide rapid HIV testing with those HIV counselors. We believe that this language would provide a good balance in allowing non-Office of AIDS funded local health jurisdictions the ability to continue to provide rapid HIV testing with necessary training and quality assurance in place without creating a local mandate, unfunded local mandate.
So, unintended consequence here that those that would be able to provide the rapid tests with their own funds would be out of compliance with statute.
Right.
Very good. Do we have any public comment on this?
Chair and members, Kathy Mossberg with the San Francisco AIDS Foundation, and we want to thank this committee and the staff for working with us on this, and obviously the Department of Health and the Office of AIDS. This is one of those unforeseen consequences when one reduces the budget by $85 million. We have continued to pick up the pieces. This is one of those pieces we want to pick up. As we have limited dollars, testing is very key in prevention and about one of the only things we have left, or one of the few things. And so we had been contacted by some jurisdictions who have a great amount of confusion around the law and the statute, and so this trailer bill language will go a great deal way, the entire way, we think, to clarifying their confusion. So we thank you for your help on this issue.
Thank you for helping bring it to our attention. Those line item vetoes have those pesky unintended consequences.
Mr. Chair, Sue North, representing the AIDS Healthcare Foundation. We're also in support of the language. Thank you.
Thank you, Ms. North.
Michael Martinez here on behalf of the Los Angeles Gay and Lesbian Center in strong support of the earlier comments and the placeholder trailer bill language, as well as CARE Sacramento. Thank you.
Thank you, Mr. Martinez. Any other public comment? Questions from the committee? Finance?
Ellen Moratti, Department of Finance.
I want to make sure your red button is depressed.
Thank you. Ellen Moratti, Department of Finance. Finance has no position on this placeholder language at this time. We are still in the process of reviewing it.
Very good. All right. Thank you. So if there's no objection from the committee, we will move to adopt and accept the placeholder trailer bill language. Thank you, Mr. Liu. Health and Human Services, please join us. This is our last discussion item on our first agenda.
Good morning.
Good morning. Welcome back.
Thank you. Good to be back. The committee requested that I respond to a couple of questions regarding Health Information Exchange, so I'd like to do that now.
Please.
My name's Jonah Frolick, Deputy Secretary, Health Information Technology at the Health and Human Services Agency. By way of background, the Health Information Exchange is a component of HITECH, which is a very large federal program for health information technology. The program is part of the stimulus package. May see up to $4 billion in incentive payments being made to California providers and hospitals. It's the biggest kind of program of its kind. It's an incredible opportunity to really make significant change to our healthcare delivery system. The state had an opportunity under this program for health information exchange to apply for a federal grant, and also had the option of designating an entity to do so on its behalf and on our behalf. We made the decision to apply for that federal grant and then enter into a grant agreement with an entity that we selected through a request for proposal. We did so because we felt we had the opportunity, therefore, to have additional oversight over that entity through a grant agreement. So it provided an additional lever for us to be able to have that, that oversight. There are two questions in particular, and by the way, that when looking across the other states and territories, 54 states and territories that applied for this program, about 2/3 are pursuing the same path that we are, so we're very much in alignment with those. The two questions in particular that I'd like to respond to, or that require additional clarification, around the implementation plan and key next steps. First, in terms of the implementation plan, we entered into a grant agreement with a group called Cali Connect that was selected through the request for information. A little shy of $700,000 is the original grant agreement. Since then, that organization has hosted 3 board meetings. It now has 10 board seats, and will have a total of 22 when fully seated. Right now, they're in the process of seating the additional private sector seats. They have an open process and call for nominations for specific designated seats. And 4 state representatives were sent letters this week to join the board. And the expectation is that that would happen by June. Second, it's very important to note that board composition is in alignment with SB 337, which is Senator Alquist's bill.
Right on cue. Senator, welcome back.
Perfectly timed.
Praising your work again.
Absolutely. And we wanted to ensure that we were in alignment, and that Cali Connect was in alignment, and their board composition was in alignment with that bill and the other tenets of that bill. The framework right now for the implementation plan is being developed by Cali Connect. They've had an opportunity through these board meetings to discuss it with the board. In these meetings are public. They are developing a communication plan. They are developing a detailed work plan, and the beginnings of a business and operational plan. Implementation plan. So we expect all of those to be completed by towards the end of June. And that is part of the grant agreement. There are a set of work groups that were created during our strategic and operational planning process that our agency supported. Those work groups are being transitioned into this new organization. They will be held in public, as we did as well. We anticipate that they will change somewhat. As they were originally structured for planning, they are now being guided to do operations. So they are going to be, for example, the technical committee weighing in on things like the requirements of an RFP and making selection of vendors. So it's important that we have the right, or that Cali Connect has the right people on those committees. Third is that the conflicts of interest policies and bylaws are being formed. They've had 2 board meetings to discuss these particular issues, and Health and Human Services Agency is providing guidance and letters to them to make sure that they, first of all, again, are in alignment with SB 337, which had language around conflicts of interest. And that they ensure that they have a very fair, open, and transparent way of conducting business. And fourth, CEO recruitment is underway. They had almost 24 applicants, highly qualified, and are in the process of selecting from a CEO and hope to have that decision in June. So they've been very busy in the last month. Finally, on key next steps, we are working as the agency with the Office of the National Coordinator. They are the grantor. And we submitted a strategic and operational plan, and once they accept that, and that was on April 6th, once they accept that, it will trigger the release and state access to the remaining $37.7 million grant. We have $1 million accessible to us right now, and so we can't access the remaining funds until they approve it. I spoke with them 2 days ago, and they spoke very highly of our plan, so we do anticipate that we will be able to proceed in short order.
Congratulations.
Thank you. We'll continue to provide additional guidance and policy directives to Cali Connect over the course of the grant agreement, and especially over the next 6 weeks. We will be developing a grant agreement amendment by the end of June, ideally by the middle of June, so that they can proceed to the next steps. They will have to meet the initial requirements that they've set out in this $700,000 agreement, but we want them to be able to continue smoothly so that they can actually release and issue an RFP, procure vendors and contracts, and fully staff up. I think the last thing that I'll say, and then I'll leave it there, is that it's important to recognize that, again, HIE, Health Information Exchange, is one component of high-tech, of this federal program. Our agency recognizes that, and we have created a coordinating committee where we've convened it. It includes the Department of Healthcare Services and the Medi-Cal program, which anticipates $1.4 billion in incentives to be administered federal funds to Medi-Cal providers. It includes the regional extension centers, which is at least $45 million in technical assistance to priority primary care providers, community clinics, and public hospitals. It includes the California Telehealth Network, which is a $22.1 million broadband network for rural providers, workforce initiative programs, a group called the Beacon Grant Initiative in San Diego, and others. So it's a committee that is charged with coordinating all of these activities and ensuring that we can actually show improvements in care using health IT and ultimately down the road reduce cost. With that, I'll end my comments.
Thank you very much, Mr. Froelich. It was great to have you at the informational hearing that we had on this that Senator Ahlquist had called for, and thank you, Senator Ahlquist, for your attention to what is really a revolutionary stage in which we find ourselves, a completely new way of doing medicine and delivering health care services. So you've got your hands full. I did have one question. I'm sure Senator Ahlquist has some comments as well. There is a state match requirement,
yes,
and that we're proposing $4.4 million in-kind contributions. Can you tell us what those in-kind contributions look like?
Those in-kind contributions are staff and staff resources. So they include myself. They include staff and resources at the Office of Health Information Integrity. That office, as I think I described in my comments, are responsible for oversight of privacy and security policies with respect to health information exchange. So over the course of the next 4+ years, they are going to continue to develop privacy and security policies and make recommendations to our agency, and ideally working with our legislative colleagues to propose potential regulatory and even statutory language that might be required to support safe, secure health information exchange. It's a critical component. We call it the trust framework that will enable hospitals, clinics, and providers to safely and securely exchange information, and those resources are going to continue to do that over the course of the program. So those are allowable under this federal program. They were approved by ONC.
Thank you.
Sure.
Senator.
Thank you. Thank you for your good work in this area. And with the signing into law last year of SB 377, and I'm not going to go into a lot of detail because a lot was covered before I was able to come back, my last piece of legislation established the framework for the governance for the HIE. And the governor designated Cal eConnect as the entity. And Health and Human Services received a $38.8 million federal stimulus grant. I believe that a lot of the really good questions were asked in this area. And so a couple things I would like to say. I'll be working with Sub 3 on trailer bill language for the summer, which will be quickly upon us. I think you answered some of the larger questions, like what is the purpose and the goal? And if you haven't answered something, why don't you just let me know, and that we'll get through this pretty quickly. What are the major milestones over the next year for which Cal eConnect will receive payments from agency out of the requested $17 million? And perhaps you answered that already.
Just to be as clear as I can be, some of the major milestones include they have to have a fully seated board of directors and a CEO. They have to develop a detailed implementation plan, a revised budget, and requirements for an RFP. Those are the main primary first set of goals that they have to hit. The second set of milestones will include the issuing of an RFP and the award of contracts for what we call these core and value-added services. These are these provider directories and lab results reporting clearinghouses. That's a second major milestone. A third major milestone is going to be providing either grants or contracts to expand what we call the HIE footprint of existing information exchange organizations. So there are 9 in California today. They are going to be creating a program to award grants and contracts to expand their footprint and expand their scope so that more can actually participate in HIE and get access to the $4 billion in incentive funds.
Great. Thank you, and I really appreciate the framework piece of this. My last question is just more of a technical item.
Sure.
The proposed services provided by Cali Connect include registries to identify providers and legal entities, such as clinics and hospitals, who exchange data, but it does not include a registry to identify individual patient records.
Right.
How will the exchange ensure that data from different individuals with similar identifiers, such as similar names, as an example, there are at least 2 other Elaine Ahlquist in the state of California, so that they don't get mixed up?
No one could confuse you with anyone.
There's only
and only one senator. It's an excellent question, and it was a question that was debated heavily in the policy and technical committees in the strategic planning process. The fundamental answer, the basic answer to that question is, at this stage, for what we call stage 1 of meaningful use, the beginning of the program, having a patient identifier wasn't actually required for the providers to meet their meaningful use requirements and get their incentives. And the reason is that it's what the providers need to do to exchange. They need to deliver documents to each other. They need to be able to identify each other, much the way a fax machine is used today from one provider to another to send a fax from one office to another. You don't actually need to have a unique patient identifier, but you have things like the patient name, their date of birth, and when the provider picks that up on the fax machine and the patient comes into the office, they know who that is. The same process is going to be happening at this stage for health information exchange. Going forward in the future, we expect...
Because I don't think that's quite definitive enough for the future.
I'm sorry?
I think it needs a little more work to be done for the future.
Okay. Yes, I do believe that we will need to continue to work on this, and in the future...
In this one area.
Right, right. And we will work more on that.
Okay, and we'll be happy to continue the conversation.
Absolutely.
Thank you.
Thank you, Senator. Do we have any public comment on this last discussion item on our first agenda? If not, the motion is going to be to approve the positions and the funding as proposed, and also to modify the proposed budget bill language as noted, and to adopt the placeholder trailer bill language.
Thank you very much.
All right. Thank you, Mr. Froelich. Continued success.
Thank you.
So that concludes our major and first agenda, and we have a couple items on our second agenda. Lead the way.
Mr. Chairman, if it's possible, I'd like to add on to the votes taken at the beginning of the hearing. I don't know if you want to do that now or if you want to...
We'll do it right now.
Okay, perfect.
Senator Ashburn, we had unanimous votes on the vote-only calendar. Did you want to take that issue by issue, or what is your desire?
We'll have to go issue by issue.
Okay. Let me pull that out then. So the first item is on page 2, Emergency Medical Services Authority. The motion was to approve the recommendation.
Aye.
All right, so we'll make that 3 aye votes on that first item. Page 3 was newly qualified legal immigrant adults in Medi-Cal. And this was to reject the governor's proposal.
No.
So we'll make that a 2-to-1 vote. Persons permanently residing under color of law, Prukal, was on page 4. The motion was to reject the governor's proposal.
No.
So that's a 2-to-1 vote. On page 5, we have receipt of federal funds and restoration of family planning rates. The motion was to reject the governor's proposal.
No.
We'll make that a 2-to-1 vote. On page 6, the governor's proposal to eliminate adult day health care. The motion was to reject the governor's proposal.
No.
So that's a 2-to-1 vote. On page 7, request for state staff under federal money follows the person. The motion was to approve with an adjustment.
Aye.
That's a 3-0 vote on page 7. And on page 8, the issue is breast and cervical cancer treatment program. The motion was to approve the recommendation.
No.
That's a 2-to-1 vote. Page 9 is intermediate care facility for developmentally disabled. The motion was to approve the recommendation.
Aye.
That's a 3-0 vote on page 9. Page 10, Medi-Cal Targeted Case Management Program. The motion was to approve the recommendation.
Aye.
We'll make that a 3-0 vote on page 10. Page 11 is continuation of Health and Information Portability and Accountability Act, and the motion was to approve the recommendation.
Aye.
3-0 vote on page 11. And then we have on page 12, state positions for AB 32. The motion was to approve the recommendation.
No.
2-to-1 on page 12. And then the last item on page 14, grant for environmental change and tobacco cessation. The motion was to approve the recommendation.
Aye.
3-0 on page 14. That takes care of our vote-only calendar.
Those are the ones.
And then our discussion items.
On page 27, Medi-Cal Management Information System.
On page 27, this is state staff for Medi-Cal Management Information System.
The LAO recommendation.
And we were accepting the LAO recommendation.
Okay.
Aye.
So we'll make that a 3-0 vote.
And then on page 30, on HIV testing.
And then we'll move to the Department of Public Health on HIV testing. The motion was to accept the trailer bill language.
Aye.
3-0 on that. And I think we're all caught up. All right. Thank you.
Do you want this? Don't we take that back to your office?
I've got it. So moving on to our agenda number 2. Thank you.
Two things for you to know.
Yes. All right. Agenda 2. We have 2 items on our vote-only agenda. Both items have been presented before the committee, but I understand that the Department of Finance has a comment, or administration does?
Mr. Chair, members, Pete Chervinka, Department of Social Services. I appreciate recognizing it's vote only. I just wanted to be officially on the record. The governor signed the AB on your first item. The governor signed this legislation. We like the policy behind it. Not funding it was a fiscally driven decision. We appreciate the staff recommendation here to provide some level of resources here, but we wanted to be on record that we had requested originally 4 positions to make this work happen. And at this lower level, progress may not be at the rate of everybody else's expectations or original expectations. So we just appreciate the opportunity to be on the record for that. Thank you.
So noted, and you are on the record.
And Mr. Chairman, thank you. John Wardlaw, Department of Finance. We'd like to further reiterate what the department has indicated.
Very good. Thank you. And Senators, do you want to take these one by one, or should we just one by one?
Yeah, let's do them.
Okay. So our first issue, which is the Resource Family Approval Pilot. We'll call the roll.
Senator Leno. Senator Leno.
And the motion, of course, is to accept the recommendation. Aye.
Senator Alquist.
Aye.
Ashburn.
No. 2-1. And then the second vote-only issue is in-home support services.
Mr. Chair.
Yes.
I'm sorry, if I may. Adam Dorsey, Department of Finance. Again, here the administration would oppose the change.
So noted. Thank you. And the motion is to reject the proposed funding to continue this one-time augmentation.
Senator Leno?
Aye.
Senator Alquist?
Aye.
Senator Ashburn?
No. 2-1. Very good. That takes care of our vote-only agenda. And then we will get to our discussion issues. Department of Social Services.
My colleague Manuel Romero will come to address this issue.
Thank you, Mr. Romero. Proposed changes to the state hearing procedures and penalties.
Good afternoon, Mr. Chairperson and Senator Alquist and Senator Ashburn. My name is Manuel Romero, and I'm the Chief Administrative Law Judge and Deputy Director for the State Hearings Division for the Department of Social Services. We have before you a proposal which calls for some changes, two basic changes that we're seeking, or in the alternative, additional funding to be able to handle the increased workload and the penalties that will flow as a result of having the increased workload and our inability to handle that with the existing resources. Now, briefly on the proposal, we're proposing two elements to of change. The first one would be to allow the department to set hearings via video conference the same as an equivalent to in person. We would still provide in-person hearings, and in fact, we could not overnight change the ability to move wholesale to video conference, and that would not happen. Our capability currently is for 11. We have 11 endpoints in terms of video conference equipment. And we do have video equipment in all of the largest counties at this point. But we would not be able to overnight or even over the course of the next several years be able to move completely to video conferencing. But we do get the flexibility to be able to set hearings via video conference and be able to conduct all hearings in one given site via video. And that's where we're going to get the savings in terms of the ALJ's travel time, which now can be redirected to writing decisions, which directly then affects the ability to be timely on decisions. We would also retain or have as an element a good cause, so that even if a matter is set or a case is set via video, a claimant will still have the ability under the proposed change to request an in-person and for good cause. Now, the determination of good cause, we propose that should be the product of consultation, input, collaboration with stakeholders, and particularly the advocate community, and that we would seek to implement this first by ACL and then move to regulations where we further define that. But by way of example, we would look at issues such as ADA or disability that presented themselves that would argue for or would be good cause for having an in-person as opposed to a video conference hearing. Sometimes the nature of a hearing is you have numerous witnesses, or it could go multiple days. It make more sense to have that done in person. Likewise, having a case where we already know ahead or in advance, both from either the county or the advocates or both, who may be representing, the authorized representative may be representing that case, that it may be a very difficult case to manage, and that having a judge in person would be more effective. Those are examples of where we believe good cause would be present to allow a in-person to hearing instead of a video conference hearing. I think that the concern about whether video conference diminishes due process that claimants have that's provided by an in-person, the only element that changes in the way that we do business when there's a video conferencing is that the way in which documents get transmitted is via fax. But the quality of the video equipment that we currently have allows you to adjust so that you can actually see very close up the face of the judge judge as well as the face of the claimants. And you can see demeanor, you can observe everything that's going on in that hearing room. And the only thing that's missing is that you have the judge physically not present in that room, but all the other parties are present in a county location for purposes of how the hearing is conducted. That's the piece on the video conferencing. The second piece of this is basically proposing codification of the penalty structure, which now is imposed upon the department by the Ball and King court orders. And what the proposal is that we would take that penalty structure and have it in statute so that all the key elements of that, the key element of that Ball and King order is that the department is to pay penalties for decisions that are untimely. And untimely means cases in food stamps that are not decided within 60 days from the day of the hearing request to the day that the decision was rendered. If we're late, we start paying penalties on those cases. On all other cases, for CalWorks, IHSS, Medicare, Medi-Cal, all of those are 90 days, so there's a 90-day time frame. Penalties start to run at a minimum $5 per day, and then increase per month $250 per day with no limit for every month that our overall timeliness on all types of cases falls below 95%. Now, in trying to figure out how can we try to do the existing workload, which, by the way, has increased over the past 3 years by 23%. Our hearing requests have gone up by 23%. The hearing held has gone up by 26%, and trying to figure out how can we handle that increased workload without additional resources. This piece of our process is important, because if we can hold down the amounts of penalties that we pay, it, along with getting more efficient on the way that we conduct hearings with a video piece, we believe that we can attain enough cost avoidance to be able to do the work without asking for any more resources. The penalty piece has the various modifications, the following modifications. First, we would ask for dropping that 95 to 90%. We have, looking over the historical overall timeliness for us, it's been at about 93.5%. And so that's why we wind up with the increases. The main reason for why we have the penalties right now is that workload increase and not having the additional resources. And that's why the penalties have gone up since 04-05 from approximately $5,000 to this year is going to be close to over $450,000. So that's significant, and they will only continue to go up as our workload increases and we don't get the resources necessary to handle that workload. So that's the reason for seeking that 95 down to a 90%, which is still a very high threshold for us to have the concern that I think has been expressed by advocates. The incentive will be gone if we toy with the penalty structure. I think it still remains when we have it at 90%. The other piece is that we want to take out 8 paid pending cases. The department believes that the intent of the Ball and King order and the penalty structure was to ensure that harm did not come from late decisions to those claimants who were deprived of having their benefits in a timely manner. So individuals who are currently seeking aid, so those would mean denials, or persons who are still receiving aid and wish to continue on aid who are terminated, those categories of folks really do endure harm from a late decision. We're not proposing to change anything relative to the Ball and King orders as to those categories as individuals. What we are proposing are those that don't have that harm, such as folks that continue to receive aid paid pending from the time that they request a hearing all the way through the decision. There's no harm that occurs from a decision being late because the claimant actually received their benefits. Likewise, with respect to the category of claimants who are no longer receiving aid, they've been off of aid for a year, 2 years, 3 years, now an overpayment comes, and there may be a late decision in that case case, the claimant's no longer receiving benefits, but a late decision, they are entitled under the current penalty structure to get a penalty payment. Again, under the rationale that there's no direct harm from a late decision, that kind of case should also be removed from the calculation of what goes into the formula of determining the penalty structure. The last piece has to do with the spike in cases that we experience every time there's a major change in law, whether it's federal law or state law. We, as a State Hearings Division, don't have the capacity overnight when there's an implementation date to be able to handle that spike that we get hit with. So there's going to be timeliness issues, and so what we're asking for is basically a 12-month period to not have penalties flow from those cases due to untimeliness and they would have to be linked directly to any case which was the result of a direct result of a change in law. That in a kind of in a nutshell is what the proposal is around the modifications for the penalty structure. We do, in the alternative, are asking for funding for 6 ALJs. If we don't get that amount of judges, we will have to pay out of the general fund any penalties, because we are not allowed to be able to charge any federal funds. So anything that we pay in penalties comes out solely out of general fund money. In lieu of the 6 LJs, we're asking for these modifications or these changes that would require statutory change.
And not unlike the penalties, the ALJs come out of the general fund as well.
Well, the ALJs come out, a portion of it comes out of the ALJ, but we do get federal funds. So the 1.4 that we're asking for, there's help me here, finance. It's 900. Let's see.
It's about 50%.
Yeah, it's 50%. 431,000 out of that 900,000 would be in general fund.
Okay. Is there any public comment? Please step forward. Public comment is stepping forward. Elio? You sure? I'll take that as a no. Thank you. No, thank you. Yes.
Mr. Chair, Mike Carroll with the Western Center on Law and Poverty. We do have some concerns about the proposal, about the changes to the state's hearings division. And let me just say that for us, I mean, we represent legal service programs who actually conduct these hearings. I mean, this is the crux of due process right here, the opportunity for a party to be able to go before the judge and face-to-face have their issues seen. And I think there's this, the key goal of due process is that people feel like they've been treated fairly through this process. And when sometimes when folks have to sit in a room at the county office next to the county and have to explain why it is they think they should get some benefits that they've been denied, that can be a very intimidating situation when they're in that situation. And many families just kind of quit. They give up. They feel like they can't win against the system in that environment. I mean, the way the law works right now is the respondent the claimant can choose to have a video conference, but the right lies with the person, not with the Department of Social Services. In previous iterations of this, we have explained that we think there are ways that the department can get to the savings they want around video conferencing without having to resort to taking the right to to an in-person hearing away from claimants. And we look forward to working with the committee and the department on finding other ways that we can get perhaps to some of the savings that they desire without having to do some of the more draconian things that are being suggested. And let me just say that while it may be the case that someone who is getting aid paid pending doesn't, they haven't lost benefits, but the other side of that is that they could. I mean, the county is challenging their benefits. They may be challenging and are seeking an overpayment. In other words, the family has a cloud over their head as they go forward and then try to participate in the program. And if those are allowed to last for months and months and months, then the family gets very insecure about their situation. That's why we have timeliness remedies. That's why we have these approaches to make sure that people get a decision, good or bad. They get a decision. They can move forward with what they need to do. So we think that is a very important important thing that we wouldn't want to see lost. The other issue that we would note is while we have a real problem, I think, with this delay for 12 months of being able to bring cases where there's been a significant or a major statutory change to a federal or state program. One, we think that is very vague, and we don't know what that standard means. But secondly, and more importantly, really it seems to us that what this does is it means that, for example, last year when the administration came in and insisted on major changes to the IHSS program, which could eliminate benefits for a large swath of the population, that caseload may not be able to go and fight that claim, that new decision by the county to deny benefits to folks. That's what those kind of changes would mean. It seems to us that if the administration wanted to seek those kind of changes in statute or in IHSS or in CalWORKS or other programs, they should not now be allowed to escape the scrutiny that they get for those decisions. And it seems to us that that is really what may be at hand here. So we concur with the staff's recommendation. We think if push came to shove, it would be better to give Judge Romero some more assistance to make sure that the families get their cases heard in a timely fashion. Thank you.
Thank you, Mr. Harold. Anybody else?
Michael Martinez here on behalf of the Legal Aid Association of California, representing more than 70 legal aid organizations throughout the state. And certainly agree with a lot of what my colleague has said, and really does, we believe, flies in the face of due process for claimants. And so we do approve of the staff recommendation and the analysis. Thank you.
Thank you, Mr. Martinez.
Kevin Ansley, Coalition California Welfare Rights Organizations. We also support the staff recommendation in the previous testimony. Thank you.
Thank you, sir. Anyone else? We will conclude public comment. Committee members, comments, questions? So thank you, Mr. Romero, for walking us through the proposal.
Thank you.
As chair of the Public Safety Committee, we have these discussions about video conferencing for hours on end. So I'm not doubting that there could be some savings here for you, but at the same time, I think this is really worthy of a policy committee conversation. So the motion here, and at the request of Senator Ashburn, we're going to break it into two different motions. So the first one would be to reject the proposed trailer bill language, and we will call the roll on that.
Senator Leno?
Aye.
Senator Alquist? Aye. Senator Ashburn?
No. And that passes 2-1. And then the second motion will be to approve the funding for 3 of the 6 positions. So that's approximately $450 for those 3 positions for the additional ALJs.
Senator Leno?
Aye.
Senator Alquist? Aye. Senator Ashburn?
Aye.
So we have a 3-0 on that. Thank you again, Mr. Romero.
Thank you.
Finance, thank you. LAO, thank you. And committee members, with no further business before the committee,
Mr. Chair.
we are adjourned.